Good evening, everybody. For the next 20 minutes or so, I'll be talking on looking behind the just BP control at risk patients and whether our ARBs are equivalent to ACEIs. All of us know diabetes and hypertension are important causes of cardiovascular disease. And through a panoply of mechanisms, as you can see on the slide, they produce cardiovascular disease, macrovascular disease, as well as microvascular disease. Now, when we look at the management strategies for diabetes and hypertension, it is a multifactorial approach based on the lifestyle management, the medical management of hyperglycemia, hypertension, dyslipidemia, and many other factors like smoking and other factors. So we have to adopt a multi-pronged approach to produce cardiovascular risk reduction. Now, when we look at the lifestyle management, this is the famous look-ahead study which showed that intensive lifestyle intervention can produce sustained weight loss and improvement in fitness, glycemic control, reduction in the CVD risk factors in individuals with diabetes, but this intensive lifestyle intervention failed to improve the CV risk in diabetics in the long run. The second feature of management is the glycemic control, and all of us know glycemic control does not significantly alter macrovascular disease, although it has a great impact on microvascular disease. And these are the landmark trials, the ADVANCE, the ACCORD, and VADT, which failed to show improvement in macrovascular disease, and the ACCORD in particular showed increase in the cardiovascular mortality. The previous landmark trials, as you can see, the UKPDS and DCTs, although they failed to show any benefit at the end of trial, but long-term follow-up, as you can see, they showed reduction in the cardiovascular events. And this is because the treatment was initiated at the time of diagnosis, and statins and other powerful drugs were not available at time, and the benefit was seen after many years when the long-term follow-up of these trials were conducted. As you can see, there's a reduction in fatal and non-fatal stroke, and also reduction in the fatal and non-fatal MI. Microvascular complications, of course, were definitely affected. Now, when we look at the strategies for managing hypertension, this is the HOT trial, which very clearly shows that a blood pressure, diastolic blood pressure less than 80 is very appropriate for diabetic patient. It produces greater risk reduction compared to a blood pressure 90 and compared to a blood pressure of 85. And this shows the different cutoff points for diagnosis of hypertension in the current guidelines. But what is universal with all the guidelines is the goal is 130 by 80, which we always try to achieve. The ACCORD trial, which compared two blood pressure subsets, 120 and 140, failed to show that a blood pressure of 120 would be better than 140. The primary endpoint of cardiovascular death, MI, and stroke failed to show any change, although strokes were reduced. Now, we often say rockers is an integral part of treatment of hypertension in patients with diabetes, and there are several reasons for this. One of the reasons is as the dysglycemia increases, as you can see in this slide, from 90 to 270 and onwards, the angiotensin level, angiotensin 2 levels also increases. And if you look at these specimens, the density of ACE, the density of angiotensin is also markedly increased in diabetics kidney compared to the non-diabetic kidney. And that's why I say RAS blockers should be an integral part of therapy of diabetic hypertensives, although all of them require combination therapy in the long run. Now, this is the famous advanced trial. You can see ACI, perindopril plus indamamide showed a statistically significant reduction in the cardiovascular endpoint. You can see a 14% reduction in the total mortality, 18% reduction in cardiovascular death, 9% reduction in the major vascular event, and 14% reduction in the total coronary events, and a 21% reduction in the total renal events. Most of the guidelines do not differentiate AC inhibitors from ARBs, but let's look at some of this interesting data. Now, when we look at the data of ARBs, you can see there is an increase in myocardial infarction with many ARB trials. You can see IADNT trial, the CHARM, the value, the I-preserve, the scope, the life and on-target. All these trials have shown an increase in myocardial infarction. When we compare it to the AC inhibitor, you can see there is a decrease in the myocardial infarction. So the data shows ARBs increases myocardial infarction, and AC inhibitor decreases myocardial infarction. More interesting is the fact when we look at the duration of trial of AC inhibitors, as the duration the trial increases, there is greater reduction in AMI, and you can see in this slide. So longer is the duration of trial with AC inhibitors, greater is the decrease in AMI, very clearly shown in this slide. Now, this is another data comparing ACE inhibitors with ARBs, and again, you can see at the right side, AC inhibitors decreases myocardial infarction, whereas if you look at the ARBs, there's an 8% increase in the myocardial infarction. Those patients who don't have left ventricular dysfunction or heart failure, this is the data from AC inhibitors. Again, you can see there's a significant reduction in various cardiovascular events. And this is another comparison in diabetic patients. If you look at the results with AC inhibitors, all-cause mortality decreased by 13%, ARB by -6%, CV mortality decreased by 17%, whereas with ARB it is increased by 21%, cardiovascular event decreased by 14%, with ARB is -6%, and myocardial infarction decreased by 21%, ARB 11%, and heart failure -19 with AC inhibitors and -30 with ARBs, and stroke -5% with AC inhibitors and 0%. Now, this is another meta-analysis, and you can see the overall results indicate 9 to 11% risk reduction in all-cause mortality, 10 to 17% risk reduction in cardiovascular mortality, and 17 to 19% reduction in AMI. And this is another data which again shows the same thing which we are talking, that the overall reduction in all-cause mortality resulted almost completely from class of AC inhibitors, which are associated with a statistically significant 10% reduction in all-cause mortality, but there was no mortality reduction with ARBs. And this is another data showing same thing. Now, when we look at the BPLTTC meta-analysis, you can see AC inhibitors, ARBs, they have same, but when you look at CHD, you can see AC inhibitors are better compared to ARBs. The ARBs is to the right of the midline, the AC are to the left of the midline, clearly indicating beneficial effects. Now, this is again very interesting data on mortality reduction. If we look at the subset of patients with hypertension, AC inhibitors decrease mortality. The one with dark blue, ARB, only a slight difference. Diabetic subset, AC inhibitors decrease mortality, ARBs increase mortality. CAD, AC inhibitors decrease mortality, ARBs increase mortality. And high risk, AC inhibitors decrease mortality, and ARBs slight increase in the mortality, clearly showing that ARBs are superior compared to ACE inhibitors are superior compared to ARBs. And this is another data which again shows that with AC inhibitors, the all-cause mortality, if you look at it, the hazard ratio is 0.89, whereas if you look at the ARBs, is 1.09, again showing benefit. CV mortality hazard ratio of ACI is 0.83, whereas 1.02, and MI also there's a decrease, and although this is only a numerical decrease. And this is another data comparing both these molecules, and you can see treatment with ACE inhibitors is associated with significant reduction in all-cause mortality, and there's less cardiovascular events, whereas there's no significant decrease in the occurrence of all-cause mortality or cardiovascular death. And further, when you look, the cardiovascular events, as you can see on the slide, are lesser with ACE inhibitors compared to the ARBs. And this is another data from the diabetic subset, which shows ACE inhibitors significantly reduce the risk of all-cause mortality by 13%, cardiovascular death by 17%, and major cardiovascular event by 14%, including myocardial infarction by 21%. But whenever we are treating diabetic hypertensive, a multi-pronged approach has to be followed, as was shown with the STENO2. This is data at the end of 96 months. You can see a reduction of 53% with the multi-pronged approach, and the data 5 years later showed a 59% reduction, and the data at the end of 21 years, you can see great benefit, survival benefit of 7.9 years, and CVD-free survival of 8.9 years. So multi-pronged approach over many, many years give very fruitful results. When it comes to the question of kidneys, that is treating hypertension and diabetics with CKD, both agents can be used. Combination therapy is required in vast majority of patients in the long runs. But with ACE inhibitors, the trial has been conducted more with type 1 diabetes, and ARBs, more often the trial have been conducted with type 2 diabetes. That's why we see ARBs more commonly used in type 2 diabetes and ACE inhibitors more in type 1. Now, when we look at the trajectory of CKD, now a normal individual, the decline in eGFR is 0.9 ml per hour per year. When these patients develop diabetic CKD, the decline is roughly 10 ml per year. Prior to RAS blockers, many of these patients were submitted to dialysis and renal transplant. But RAS came as a big revolution in 2005, and it decreased the eGFR from 10 to 4.4, roughly 50% reduction. The second revolution came with SGLT2 inhibitors, which decreased the declining, which improved the decline in GFR by another 58%. And we are very interested to look at the results of two new trials with finerenone, which are the non-steroidal MRAs. Both these, this drug has further improved the decline in eGFR by significant proportions. So we will have a substantial decline in GVR when we use all these three drugs. So although we do not have a quick fix for CKD, but all these three groups of drugs are going to produce great improvement in the trajectory of CKD. The data with the non-steroidal MRA is going to be presented shortly in the American Society of Nephrology. When we treat these patients, we always look at the potassium levels. So why there is a paradoxical response between ACE inhibitors and ARB? Now, the several factors are responsible. One of the factors, of course, we know is the bradykinin. ACE inhibitors increases bradykinin. The other factors is when we use ARBs, there is an increase in the level of angiotensin 2, and it is believed that this produces hypertrophy, remodeling, destabilization of the plaque, and inflammation, which may contribute to the adverse results. And the stimulation of 83 receptors produces endothelial dysfunction and prothrombotic milieu, and 84 stimulation is believed that increases pie release. The other reasons for this is that the excess levels of angiotensin 2, they act on the 82 receptor and augment matrix metabolinases 1, which produces plaque destabilization. And the third, this shows that AC inhibitors decreases the level of MMP1. And the other reason is that the pi levels are altered with ARBs. With ACE inhibitors, you can see they decreases pi 1, which results in a stabilization of plaque, compared to ARB, which increases pi 1 levels or produces a lesser decrease. So these are some of the reasons for the discordant result between AC inhibitors and ARBs. So that when patients develop atherosclerosis, endothelial dysfunction is the first step, and this sets in a panoply of pathways, thrombotic pathways, inflammatory pathways, vasoconstrictor pathways, vascular remodeling plaque, and ultimately it produces cardiovascular events. When AC inhibitors are introduced, all these pathways are favorably altered and you get reduction in the clinical events. The take-home message is clinical evidence, as I've already shown you, suggests that AC inhibitors in ARB have divergent CV effects on cardiovascular mortality and MI in high-risk patients. AC inhibitors reduce the risk of MI and mortality in high-risk hypertensive patients, as well as in diabetics, the elderly, and those with vascular disease and congestive heart failure. And ARBs, in contrast, have not shown to reduce the risk of MI or death in clinical trials. And systemic reviews further confirms that ARB lack the cardiovascular protective effects of ACB, and you can see these publications on the divergence effects of AC and ARBs. The talk.
You have any comments to make? You can unmute yourself, please.
Physicians or practitioners often ask, what is the importance of systolic? What is the importance of diastolic? What is the importance of pulse pressure? What is the importance of mean pressure? So what would be your messages for them?
Yeah, see, the thing is, in general, it was thought that systolic was more correlated to CNS, diastolic more for coronary. That was a concept. But now we know that, and pulse pressure for CNS, for strokes, actually. The concept now is changing, because if our targets are sort of maintained, then this is not going to make much difference. The problem is that though hemodynamically it makes a difference in what is going to be affected by systolic, diastolic, and pulse pressure, if we hit the targets and the variability, there's not much point talking about systolic or all these three when we treat hypertension.
And the concept of seamless control also is very attractive, because obviously if there are no variables, variability of blood pressure is going to protect the vasculature by the insults created by the surges. So rather than somebody getting 120/80 in the clinic and surging at night, it is better to have somebody's 130/90 seamlessly. Probably he is going to do well. And the gadgets that we get, as you mentioned, are going to help us to monitor blood pressure better. Ambulatory blood pressure monitoring per se is a very cumbersome investigation. And it gives you 24-hour information, nothing beyond it. So I think these kind of gadgets which will monitor blood pressure 24/7 for a period of time is going to improve our treatment method.
Correct.
Dr. Sate, how often you utilize the smoothness index of blood pressure? Smoothness index for blood pressure. How often you utilize
it? But only thing, when we did the drug studies, actually we did not sort of look at smoothness index itself. We saw a few patients. It does make a difference. See, because all the 11 indices given. In fact, finally we looked at the vascular age and stiffness because that was the easiest way out. But we did not go into details of all the indices because it was not possible in that particular study.
If there are any questions in the chat box, we can take those. Okay, so there was a large meta-analysis related to Southeast Asia, India, which studied, I think 20,000 or more patients, and they came up with the same kind of a strategy that if you have a seamless control of blood pressure, especially Southeast Asian Indians, very tight control, that means less, about 120/80 as a, let's say, as a target, then your chances of cardiovascular events are going to be controlled a great deal. And we all know in Indians, the cardiovascular disease starts early, blood pressure for that matter starts early. And there is a lot of involvement related to the sympathetic nervous system. So for India, we have to think differently. My own personal thinking is we do underutilize beta blockers. We underutilize the doses of ACE inhibitors. We underutilize the combination that we are available with us. And our aim should be to control 120/80, whether whatever is the patient. I'm sure some allowance will be made if their patient is symptomatic. But even if a 75-year-old is asymptomatic by my treatment at 120/80, I'm ready to buy it because it is going to protect him more by way of cardiovascular event. Postural hypotension develops, then you have to allow him a little blood pressure. But that's a compromise. Our aim should be to control them tightly and control them 24/7.
Dr. Hirmat, sometimes we have diabetic patients with severe autonomic neuropathies. Moment they stand, the blood pressure drops. So how do you control these? If they lie down, they have severe hypertension. So how do you control these patients?
These are
What is
all,
your experience?
on a webinar like this, we would be talking of the 90% truth. The remaining
Yeah.
10%, we are all excellent in our own clinics managing them. But it's a tough call when they have autonomic neuropathy and they have so much BP variability on the postural. So there I would go by symptoms. I would go by the standing blood pressure as the method to control. So aim the blood pressure medication to optimize the standing blood pressure so that it doesn't get hypotension and problems thereof.
PC, one question to you. What dosage of ramipril are you using in diabetics? You know, people tend to give 1.25, 2.5 of ramipril. So what is your sort of thought? What would you recommend it? What is the minimum dose you should give?
We start with 2.5, 5, and usually build up to 10. Most of the patient tolerated well.
So this is again one more thing which is not done if you see overboard.
Yeah.
People are very skeptical about using higher doses of ramipril.
Dr. Sadek, what is your, we are seeing isolated systolic hypertension in the young also these days. So what is your take on this?
In young, I found basically the high volume row resistances are more. You know, we found that their vascular indices, in fact, were normal. Okay. And there, I think a dose of beta blocker does help, even for systolic hypertension. Because we found that the heart rate actually influences this significantly, especially in the young. In the elderly, of course, we know that we are going to use different drugs like calcium channel blockers, ARBs, and indapamide, which is in the elderly. In the younger, we have found that heart rate related jumps in the systolic blood pressure, in fact, do well with beta blockers.
Dr. Hirmat.
Question to you, Doctor. So you finish your question, Dr. Manori.
Dr. Hirmat, when we see specimens of COX, we see severe atherosclerosis above the COX. No atherosclerosis usually below the COX, and most of these children don't have any risk factors for atherosclerosis, which means that hypertension is self-sufficient to initiate and perpetuate atherosclerosis. So what is your viewpoint on statins in these patients, even if the lipids are normal? Because this is a very exciting example that none of them have dyslipidemia, the kids, yet atherosclerosis is very severe.
Yeah, I mean, it's tough to answer this question anyways because the science is not clear enough at this stage. But for that such patient, my aim would be to control blood pressure very well. The use of statins, I would wait till some more papers come out and some more clarity related to these patients come.
And
Because the pleiotropic effect of, like here, the lipid levels are normal. Now, with the advent of PCSK9, we realize that entire process is LDL related, the linear relationship. Pleiotropic effect, maybe you may not be there because PCSK9 does dramatic effects without having the pleiotropic effects of statins. So how much I would use statin for prevention of atherosclerosis for its pleiotropic effect, I have doubts in my own mind. So,
but statins being very safe drugs, will you not use them in, say, 10 milligram, looking at the autopsy specimens?
In a young person, you start and then you have to give them for next 40, 50 years. We don't know about it. So, I would wait for clarity. In these patients,
till the surgery is done or till the intervention is done?
I don't know, really. No answer to this.
See here,
The question is by Dr. Jay Shah for Dr. Manoria. What drugs would you, antihypertensive drugs, would you suggest for isolated diastolic blood pressure? Like there would be an individual who is, say, 140 by 100, 140 by 110. Then what do you do?
See, this phenomena is usually seen in young individuals. In young, we have diastolic hypertension, elderly, we have systolic hypertension. There's no drug which can control only systolic or only diastolic. So usually in young, we use ACE inhibitors. The blood pressure will be controlled. We don't have any separate drugs to control only systolic or diastolic. This is a phenomenon seen in young individuals.
Yeah, isolated. My mental note would be, we used to use enalapril in the past, but now it is all shifted to ramipril for its obvious advantages and long-term use.
and in this subset, ACEIs are much better, as you said, than calcium channel blockers.
Yeah. Calcium channel more for elderly and stiff arteries.
Okay, I think, so overall, I think we've had good discussions, not the standard routine blood pressure lectures, but thought-provoking talks. I thank, shall we stop here?
Yes, sir.
Yes, sir. Yes, sir.
It's
absolutely.
1 hour, so time-wise it is correct.
Yeah.
Yes.
So I thank both these speakers for doing a wonderful job, for their expertise, for their time, and for their zeal for teaching. We learned that hypertension is not a simple number game. It needs to be controlled beyond numbers. Dr. Manoria insisted that controlling other aspects of the risk factors, maybe by diabetes, maybe lipids, all aspects controlled, and of course control of blood pressure will lead to a better cardiovascular. Okay. So that is beyond numbers. And Dr. Sunil Sate's talk focused on thinking about the arterial stiffness, thinking about the circadian rhythms, thinking about nighttime blood pressures, thinking about the variability. So this is also going beyond numbers. By these two different ways of looking at beyond numbers, we realize that we have to come up with a treatment for our patients, tailor-made, so that the blood pressure remains below 135 and below 85. That is what my figures are, because what I mean by that is somebody sitting on 82, I don't want to add another drug. Suppose somebody is sitting on 137, 140, then I would add another drug. So my mental note is that below, so it is close to 130 and close to 80. That is how we'll control. We'll ensure that there is not much of there is smoothness index or not much of a BP variability. And we'll ensure that drugs that are used would we have pleiotropic effect to control the cardiovascular benefits or to the patient. With that, I'll stop here and hand over back to Abhishek for the formalities.
So
Thank you.
thank you, doctors. I'm Srijit. I'm the regional manager for Sanofi India Limited. For the vote of thanks, firstly, I would like to give a big salute to all the doctors, for risking your lives at the front line during this unprecedented times of COVID-19. And you are doing a great service to humanity. A big salute to each one of you at this current situation in time. For today's CME, I would like to thank Dr. J.S. Hiremat sir for chairing today's session and moderating it so well. I would like to thank the speakers, Dr. P.C. Manoria sir and Dr. Sunil Sate sir, for their fabulous talk today. I think, overall the doubts, overall the conversations were so high-level conversations, and many of the audiences sitting over here would have completely benefited from today's talk. Today, we had around 100 logins participating in this GPTO CME, and I would like to thank all the audience for taking out your valuable time and attending today's eCME. I would also like to thank my colleagues across Madhya Pradesh, Maharashtra, Goa, Chhattisgarh, Bombay City, from Sanofi, who have taken their full efforts to invite all the doctors and inviting everybody to be a part of CME. Sanofi India Limited is committed to conduct more such meetings in the